I'm Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning process for performing mechanical thrombectomies in acute ischemic stroke.
Now, 10% of strokes and TIAs in USA are due to intracranial arterial stenosis, but the percentage or the prevalence is much higher in the Asian population. And we do know that with ICADs, there is 15% annual recurrent stroke rate. Now, the most common sites are internal carotid artery and the middle cerebral artery. So what are the clues to ICAD? So if the patient has diabetes, there's history of prior stroke or TIA in the same territory, you can't find an etiology like atrial fibrillation or heart disease, there is absence of hyperdense cerebral sign on CT brain. This is an important feature that the occlusion is tapered or pencil-like. That's a clue to ICAD again. And during the procedure, you find high-grade stenosis, or there's a tendency for early reocclusion. So you are trying to recanalize, and every time the artery closes again, so you can think of an ICAD which is underlying there. There's calcification at site of occlusion, and then the lesion location itself, like the isolated supraclinoid segment, proximal to mid-basilar, distal vertebral. These are all clues to underlying ICAD. Now, this is the tapering that I was talking about. So you can see here the occlusion is tapered or pencil-like. Again here the basilar, the occlusion is pencil-like. Now if you have reocclusion or you have a futile mechanical thrombectomy, the chances are that there is an underlying ICAD which is leading to recoils. So what actually happens is that there is a pre-existing stenosis and there's an acute plaque rupture here, and that leads to thrombus formation and then occlusion at the site. Now this risks snow plowing effect with balloon angioplasty. So what actually happens is that, for example, this is MCM1 territory. There are perforators coming out of which do not have collaterals to them. Now if you do balloon angioplasty here or you do a stent angioplasty, there is likelihood that this atherosclerotic material or the thrombus will get pushed into this, will be shifted into the perforators and cause infarction. So this is the snow plow effect. So what you need to do is reduce this thrombus load first with aspiration. So aspiration catheter, remove as much thrombus as you can. Then you may try stent retriever once. One of the benefits is if you deploy a stent and then you take a contrast injection through the guide catheter or the aspiration catheter, you might be able to see the ICAD underlying the stent. So that's a good way of identifying ICAD. And then you need to give dual antiplatelet therapy to prepare for angioplasty, or you may, but since it's going to take time, so occasionally people do use bolus dose of agrastat at this stage, and that's usually half the dose of the coronary agrastat to get a quick effect. And then they do a submax balloon angioplasty once, or it may be repeated. Stent is only as a bailout situation or a last resort for flow limiting ICAD. So this is a very interesting case by Dr. Adnan Siddiqui in Buffalo, New York, Gates Vascular Institute, basilar ICAD, and they're trying to go into the left posterior cerebral artery. You can see the microcatheter dot here, and you can see the wire, and they're trying to go into the left PCA, and soon they will manage to do that. And then they did a very interesting thing here. They've actually used an FFR in this case. That's the reason why I'm showing this case here. So what they've done is they've crossed the lesion with a microcatheter. Now they've taken a check injection through the microcatheter, and now they've taken their wire out and they've replaced it with a pressure wire. FFR wire is going in, and then the microcatheter is taken out. They do the pressure reading of the stenosis, and then they do a submax balloon angioplasty. This is a 215 coronary balloon. And after this, the result shows that there's a dramatic improvement in vessel caliber. So it's not a picture perfect result, but they've done an FFR after that. So there is no data to support the FFR studies. It's just experimental thing that they are doing. But then they were satisfied with the result, and the next morning the patient is discharged as well. So for the submax angioplasty, what they recommend is that do the inflation regimen 1 atm pressure every minute. So it's very slow inflation of the balloon, and then once at the nominal pressure, hold it for 2 minutes there. And then again, it's a slow deflation, 1 atm every 30 seconds. And then once deflated, allow the reperfusion and then repeat plasty if needed. So 30 seconds and 1 minute, maybe you don't hold that long, but that's the recommendation. What they mean is go very slowly with your inflation and then hold at the nominal and then go very slowly down with your deflation. Now, this is a very interesting case that we did here. This is a 70-year-old gentleman with blocked left MCA. MCA is blocked here. It's blocked here. So we took a Sophia, and there's a very nasty bend right at this point, and Sophia could not go up, so we could not try the adapt. Then we deployed a stent here. This is a 440 Solitaire X, and with that we were able to pull Sophia up. When we took an injection through the Sophia before pulling it up, you can see that's the underlying ICAD that I was talking about. So with the stent deployed, when you take an injection, you can see that the stent is not opening up here nicely, and it's actually an ICAD there. So having known that this is ICAD, we decided to remove the stent, and once we removed it, this is the result, and it was of no use. So next we decided to do a balloon angioplasty. This is one of the initial ICAD cases that I dealt with. So I took a 1.515 emerge coronary monorail balloon to do a POBA, but then I realized that hardly the balloon itself came out of the Sophia because there was no shaft length left to come out with the balloon. So the balloon actually could not reach the site of lesion because the Sophia would not track up. As I showed earlier, that Sophia stopped much earlier, and we had to take a stent retriever up there. So the Sophia is way down in the ICA. The balloon hardly exits the Sophia. Why it hardly exits the Sophia? Because the Sophia itself is 131 centimeter long. The Y connector is another 9 centimeter length added to it, so it's around 140 centimeters. And the emerged balloon is 143 centimeter long, which means hardly 3 centimeter of the balloon itself comes out. Remaining, the shaft is inside the Sophia. So then I decided to remove Sophia so that I can gain length and take the balloon up. But when I tried to take the coronary monorail balloon up into the MCA, that tortuosity which Sophia could not cross, the balloon also could not cross with the help of cello guide. So it was not possible to take the balloon up there. So maybe if I had an over-the-wire balloon at that time, it may have been more trackable. It's more sportive to go through. But then for that, you need to have a microcatheter placed distally in the lesion, and then you've got to take a long 300 centimeter wire, place it there, then remove your microcatheter, and on top of that wire, you track your over-the-wire balloon up there, and it may reach. So the next thing we did, I knew now that in order to deliver this balloon, I have to first deliver my Sophia Plus into the MCA. So I used the anchoring technique. So I took the stent retriever, again deployed it in the lesion, not to bring some thrombus out, but just to anchor and take Sophia up into the MCA. So with the help of this stent retriever, I pulled my Sophia up, which you can see here. The Sophia is going on top of the stent, and it finally goes into the MCA. And once it reached the MCA, the intention was never to use the stent as a stent retriever, because every time I use the stent, it's going to denude the endothelium from the artery, and it's going to be more prothrombotic. So then once the Sophia was there, I brought my microcatheter in, and I sheathed the microcatheter over the stent, and I removed the stent out of the microcatheter, keeping the microcatheter in the lesion, or rather across the lesion. And then once the stent was removed, through the same microcatheter, I placed my wire back in, and I removed my microcatheter. So now I have my wire in place, I have Sophia right in MCA-M1, just proximal to the critical stenosis, and I've got a guide catheter in place. So now I took my balloon in. That's a 1.5 millimeter balloon. You can see now it's in the lesion, and I've inflated it. I've gained, and I actually removed the Y connector from the Sophia, and then it was much easier, and I gained some extra length, and the balloon came out. But the result wasn't very satisfying. So then next thing, I took a 2 into 15 millimeter emerge monorail balloon through Sophia, and I did inflation with that, and this is the final result. I did not go more aggressive than this because at that time I did not have a 2 millimeter stent on the shelf. So you ideally need a self-expanding or a balloon-mounted coronary 2 millimeter small length stents available to stent these ICADs. So you've got a choice between balloon-mounted stents and a self-expanding stent. So the balloon-mounted stents are relatively inflexible. They increase the chances of vessel rupture or dissection, and you can have snow plowing effect with them. Whereas the self-expanding stents are more navigable. They're easy to navigate. They have a low rate of side branch occlusion. They have a low rate of vasospasm, and they cause less endothelial damage. So balloon mounted stents are suitable if the vessel is at least 2 millimeter in diameter. There is no mismatch of the vessel size. The lesion length is around less than 10 millimeters, and there is no vessel tortuosity, whereas self-expanding stents are good even for a 1.5 millimeter vessel. The vessel mismatch does not bother it. Long lesions can be covered, and it's good for tortuosity as well. So there are 5 types of intracranial self-expanding stents that are currently available, and the good thing is that they can be resheathed and replaced if required, but none of them is available in Pakistan at present. So this is another case where you've got an MCA stenosis, and it was treated with a wingspan self-expanding stent. You can see the self-expanding stent, nice result here. This is a supraclinoid ICAD, and then this was again treated with a self-expanding stent. Now this is a basilar ICAD. You can see the stenosis here, and this was first treated with a 2 millimeter balloon POBA was done, and then a wingspan stent 4 millimeter has been placed from the vertebral into the basilar with a good result, but the patient came back with stroke, and on restudy the patient had stent thrombosis. You can see the filling defect here in the stent. This patient then underwent POBA with a coronary 2.5 millimeter balloon, and intracranial agrastat was given through the microcatheter placed proximal to the thrombus, and then it's a neat clean result, and the patient did well. So this is another case of M1 distal occlusion, and it had recoil of both the deviants, M2 deviants, despite of repeated balloon inflations, and finally it was decided to stent. And like interventional cardiologists doing bifurcation stenting, if you look at this one, this is also a bifurcation stenting